Welcome to the module Chronic Leukemias. My name is Karen Fancher, and I'm an Associate Professor of Pharmacy Practice at Duquesne University School of Pharmacy, as well as a Clinical Pharmacy Specialist in Oncology at the University of Pittsburgh Medical Center at Passavant Hospital, both in Pittsburgh, Pennsylvania. This presentation is part of the ASHP and ACCP Oncology Pharmacy Specialty Review course, which is designed for pharmacists seeking to obtain recertification credit or update their knowledge and skills in preparation for board certification. The activity is designed to be interactive with questions posed to you at several points. I will pause to allow you time to consider how you would answer the question. You may wish to write down your answer and the correct response in your handout. The disclosures for this presentation are listed on this slide. And these are our learning objectives. You should note that this recorded presentation will cover chronic lymphocytic leukemia and chronic myeloid leukemia, but the handout also contains information on hairy cell leukemia, so please be sure to review that as well. So I first want to thank ASHP and ACCP for asking me to do this presentation again. It's always such an honor and privilege to talk about the diseases that I love, but also hopefully for the audience to learn something. So let's get started. We're going to talk first about chronic lymphocytic leukemia, or CLL. So if you don't practice in this space, I just wanted to remind you that CLL is a progressive accumulation of small lymphocytes in the blood, lymph nodes, spleen, and bone marrow. There is a similar disease called SLL, or small lymphocytic leukemia, but for our purposes, we're not going to distinguish between them. They're usually all treated like CLL. This is a very indolent disease where we have some patients surviving for up to 20 years after their diagnosis. So what we need to keep in mind is that this is likely not curable given its indolent nature. But also, this is a disease of elderly patients. So many or most of our patients will have comorbid conditions, are on other medications. We need to be very thoughtful about our treatment given its toxicities as well as the duration that we're talking about here. So historically, we would classify CLL into stages based on what's called the Rye system or the Binet system. We could consider active surveillance for a patient without very aggressive appearing disease who was asymptomatic, or we could move into treatments at that time. All right, but again, the title of this slide, this is the historical treatment, because these staging systems were developed prior to most of the drugs we're going to mention today. And likewise, they did not include information about cytogenetics or other prognostic variables. So if you read a study on CLL, you'll probably see these terms, but in today's day and age, this is not how we decide what treatment a patient should or should not receive. In current practice, we would consider the patient's genetic mutations to help guide our therapy. So things we would consider include the immunoglobulin heavy chain variable region, or IGHV gene, and its mutation status. So if you recall, your immunoglobulins are those little Y-shaped things on the outside of B cells, and their heavy chain regions are considered or potentially able to mutate. Most of the time, we consider a mutation an adverse prognostic feature. But in this case, it's actually a favorable one to see a mutation of that region. So if a patient is already mutated, and by that we mean more than 2% of the samples, so we'll take anything really. If the patient is already mutated, that is a favorable prognostic indicator because the disease has already gone through clonal evolution. The disease has shown you what it will be. For the unmutated patients, those patients are likely to progress much faster. The disease will mutate much quicker. So in this case, we would like to see a mutation. We can also look at cytogenetics, and there are numerous ones that I will show you on the next slide, but kind of the flagship one or the hallmark one, the one that we don't want to see, is called deletion 17p. This genetic mutation is associated with a loss of the key tumor suppressor gene, TP53. So these patients have the most aggressive disease course. They have very short amount of time off treatment. They don't respond to traditional chemoimmunotherapy, and overall their median survival is much shorter. So this is a summary table to help with your studying. Again, in this day and age, we would look at the first two rows to help decide therapy. We would look at cytogenetics, and the one that we're most interested in is an unfavorable marker, deletion 17p. And likewise, we would look at the patient's IGHV status. And in this case, I'm hoping to see a mutation. A greater than 2% mutation shows a favorable prognosis. I have listed some other prognostic markers like CD38 and CD49D. These are considered experimental at this time. Okay, you can see that a higher expression of some of those other markers like ZAP70 confers an unfavorable prognosis. Likewise, if we report TP53 status, a mutation is worse. But again, this is not the way we make treatment decisions at the present time. That would just be the first two rows. So the NCCN guidelines now consider the presence or absence of the deletion 17p and TP53 mutation and IGHV mutation status as part of our treatment scheme. But we also need to consider what's at the top of this slide, and that is the individual patient in front of you. You need to consider that patient's fitness for therapy. All right, and I have fitness here in quotes because there's not a lot of good scales that are specific to oncology patients that measure fitness or performance status. All right, there are numerous ones to choose from, but none is the preferred. You need to be very thoughtful about the patient's comorbid conditions, and you also need to be very thoughtful about drug interactions, because again, the patient population we're talking about typically has a lot of polypharmacy happening. As you can see here, more than 5 medications is the norm. So again, we have to be very thoughtful about our patient's genetic information, but also their physical presence and their drug list. All right, so let's pick some therapy. So we have a retired 68-year-old male with a history of chronic kidney disease, hypertension, hypothyroidism, and hypercholesterolemia. Approximately 6 months ago, he noted significant and painful lymph node swelling in his neck and groin that did not get better with antibiotics. He returned to his family doctor, where his CBC revealed marked lymphocytosis, and flow cytometry confirmed the diagnosis of CLL. After further workup, he's been diagnosed with Bennet stage B disease. His cytogenetic analysis reveals that he has deletion 13q mutation and unmutated IGHV. He's considered to be medically fit to receive treatment, but he states that he will not accept IV medications and that he doesn't want a treatment regimen that is too complicated. So given this information, which of the following treatment regimens is the most appropriate first-line therapy for this patient? Is it A, zanubrutinib, B, duvelisib, C, pirtobrutinib, or D, venetoclax? All right, there's a lot of choices in this setting. Of the ones that I have listed for you here, the most appropriate is zanubrutinib, the Bruton's tyrosine kinase inhibitor. All right, that is a category 1 first-line recommendation in the current guidelines. So we will go through all the data for this in the next slide. All right, so our patient had first-line therapy and did not have deletion 17p. So at this time, the category 1 recommendations mostly include a Bruton's tyrosine kinase inhibitor and or a BCL2 inhibitor such as venetoclax. You will also notice that there are some anti-CD20 monoclonal antibodies on this slide, and that's because we are dealing with a B cell malignancy that is very, very likely to be CD20 positive. So our current preferred regimens, all category 1 on the left-hand side, are acalabrutinib alone or in combination with obinutuzumab, venetoclax and obinutuzumab, or zanubrutinib as a single agent. All right, if you're familiar with CLL at all, you're probably like, hey, where's ibrutinib? Kind of the prototype drug in this class. And unfortunately, or fortunately, it's been demoted. It has recently been given a Category 1 other recommended regimen status, and that's likely because of some of its toxicities, which we'll discuss later in the presentation. In very rare circumstances, we could use some of our old standbys like chemoimmunotherapy, such as FCR, but that would be for a very specific patient population that our patient did not fall into, so has to be less than 65 and IGHV mutated, which our patient was not. All right, so to briefly summarize some of the studies that got us to these recommendations, the ELEVATE-TN, or treatment-naive study, was conducted regarding acalabrutinib in the frontline setting. So this was 535 patients with previously untreated CLL, and you can see these patients were a little more frail, greater than 65 or less than 65 with comorbidities. And there was a 3-arm trial consisting of acalabrutinib alone, acalabrutinib in combination with obinutuzumab, or the standard of care at that time, chlorambucil and obinutuzumab. And the primary endpoint was progression-free survival by an independent committee. So this is a summary of some of the most important results. You can see here that both of the acalabrutinib containing arms perform better than chlorambucil and obinutuzumab in terms of median progression-free survival. All right, and again, that shouldn't be a surprise to anybody. The chlorambucil and obinutuzumab is certainly not one of the most powerful regimens that we have. So the question really became acalabrutinib alone or in combination with obinutuzumab. So the study was not designed to make that comparison, but you can see here that progression-free survival and overall survival numerically favored the combination arm, but median overall survival was not reached for any arm. So what we can take from this is that acalabrutinib in the frontline setting, either alone or in combination with obinutuzumab, certainly seems to produce some favorable results. Next, we found the Sequoia study, which compared zanubrutinib to, again, the standard of care at that time, which was bendamustine and rituximab, or BR. This is actually an ongoing phase 3 trial. This is just some of the preliminary results. Zanubrutinib versus BR in previously untreated CLL. At 24 months, the progression-free survival was very, very in favor of zanubrutinib. And this advantage was seen across some high-risk subgroups, but did not include patients with deletion 17p. But again, certainly cementing the status of zanubrutinib in the frontline setting. What about venetoclax, the BCL2 inhibitor? That was studied in the frontline setting in CLL14. So this was venetoclax and obinutuzumab versus chlorambucil and obinutuzumab, again, in previously untreated patients who did have comorbid conditions, so slightly more frail. There shouldn't be a surprise when you look at these data. Venetoclax and obinutuzumab was clearly better than the study arm, or sorry, the control arm of chlorambucil and obinutuzumab in terms of time to next treatment and what have you. What was also important to note is that both groups required growth factor in almost 50% of patients. So again, venetoclax and obinutuzumab, a clear preference in the first line setting compared to historical controls. The summary that I have here is essentially what I just said. The 72-month progression-free survival and time to next treatment were greater with venetoclax and obinutuzumab. We saw these benefits in multiple subgroups, including TP53 mutation. And again, growth factor support was often required. But what I really want to call to your attention on this slide is that the use of venetoclax and obinutuzumab is what's called fixed duration therapy, or in some cases, time-dependent therapy, in that the entire regimen is completed in 1 year. This is very large difference compared to the Bruton's tyrosine kinase inhibitors, where therapy is taken indefinitely. So for a patient who's interested in finishing therapy in a defined period of time, this may be something we would consider. In 2023, we published a very interesting study called the Gaia CLL13 study. So this was a very large study that randomized patients to one of 4 arms, either traditional chemoimmunotherapy, such as FCR or BR, 12 cycles of venetoclax and rituximab, 12 cycles of venetoclax and obinutuzumab, and 12 cycles of venetoclax, obinutuzumab, and ibrutinib. So looking here at the first hint of a possible triplet regimen in the frontline setting. Also note that all 4 of these arms were time-dependent therapy. So again, kind of where we're heading in the role of CML. This trial had multiple primary endpoints, including progression-free survival and undetectable minimal residual disease at month 15. So undetectable minimal residual disease, or MRD, again, is an emerging concept in CLL. We do not use it to make treatment decisions, whether it's a start or stop therapy at this present time. But again, if you're familiar with this literature, this is really cropping up in all of our studies. This may be where we're headed. So given the 4-arm nature of the trial, this slide may be a little complex to interpret, so let me water it down for you. So looking at the primary endpoint of progression-free survival at 3 years, venetoclax and obinutuzumab, as well as venetoclax, obinutuzumab, and ibrutinib were clearly better than chemoimmunotherapy, but we did not see that difference in the venetoclax and rituximab arm. It was not clearly better than chemoimmunotherapy. So what we can take from this is that venetoclax and obinutuzumab may be preferable to venetoclax and rituximab in the frontline setting. All right, what about the triplet regimen? Kind of what we would have expected, greater incidence of toxicity. All right, so in this slide, I've chosen to show you the incidence of grade 3 and 4 infections. But again, the overall toxicity was greater in the triplet arm. I did not show you data for minimal residual disease because, again, that's not the way we make treatment decisions. But what we can take from this is that, again, venetoclax and obinutuzumab is a clear preferred agent in the frontline setting. Triplet therapy, maybe not yet. And again, the role of rituximab in the frontline setting seems to be fading. All right, what about our old friend, ibrutinib? So you guys, ibrutinib was the first Bruton's tyrosine kinase inhibitor that came out more than a decade ago, and it certainly rocked the world of CLL at that time. It changed the way we practice and the way we manage these patients. But now we're seeing almost like a sunset on ibrutinib. Sometimes I use the analogy, like I feel like I'm sending a child off to college, like it's all grown up and it's time to go. So ibrutinib, still a reasonable choice, but has been demoted to a category 1 other recommended regimen in the first line setting. Okay. Why is that? Well, we don't seem to have clear data on whether ibrutinib has any benefit in combination regimens in the frontline setting. And its adverse effects are really declaring themselves with this much data. There are concerns about cardiac toxicity and others that I will show you in some upcoming slides. We are seeing some studies about combinations of ibrutinib and other agents, such as venetoclax. Those are not category 1 recommendations at this time. But again, ibrutinib alone would be given continuously. Ibrutinib and venetoclax would be a fixed duration of therapy. So these may be things that would sway a patient's decision. But again, I'm kind of hinting at what's coming. The adverse effects of ibrutinib have really dropped it down in our preferred agents, given some of the other agents that are available to us now. All right, so how would you choose between these options? These are my thoughts. This is not in any guidelines or paper. This is, Karen Fancher's summary slide for you. The patient and the physician and you may prefer venetoclax if we are desiring time limited or time dependent or fixed duration therapy. Again, financial concerns might play a role here, and I put question mark because, again, although therapy might stop, again, that 1 year could be quite pricey for a patient. And I would certainly consider side effects, which we'll get into in other slides. A BTKI might be preferred for a patient with TP53 mutated disease, for a patient that absolutely cannot take IV therapy, such as this anti-CD20 monoclonal antibody, for patients who don't mind taking 1 pill a day or 1 dose a day, and they have no preference about time-limited therapy, and other side effects. All right, what about our old friends chemoimmunotherapy, FCR, so fludarabine, cyclophosphamide, and rituximab, and bendamustine and rituximab, the BR regimen. These were the workhorses prior to BTKIs and BCL2 inhibitors. So do they have a role in this day and age? And the answer is maybe, but in very specific scenarios. All right, so I will show you the landmark study here. This is called CLL10. So this was previously untreated, medically fit patients. So again, at baseline, these patients were healthier than many of the patients that were enrolled in BTKI and BCL2 inhibitor studies. When we compared FCR and BR, looking now at the third row across, the median progression-free survival for all patients favored FCR, but that's in all patients. When we looked at our elderly patients, patients greater than 65, there was no difference. So the all-comers data was probably influenced by the younger, healthier patients within this cohort. There was no difference in overall survival, but there was a clear difference in toxicities. You can see here much higher incidence of grade 3 and 4 neutropenia and infections with FCR. Not shown on the slide, we were concerned about secondary malignancies and other toxicities as well. So what you can take from this is that FCR produced overall improved response, a progression-free response in all patients, but not in the elderly ones. No difference in overall survival, and there was a greater toxicity with FCR. So because of this study now, in the current NCCN guidelines, BR is an other recommended regimen, and FCR is recommended for the first-line treatment of patients in very certain circumstances, and those would be mutated IGHV, who are less than 65, and do not have significant comorbidities. So kind of that needle in the haystack of a very healthy young patient who already has mutated their IGHV. The other advantage of FCR and BR is that they are time dependent or fixed duration. These would be 6 months of therapy. So for a patient that really was drawn to that possibility, that's there. Likewise, cost is always a concern, and this short duration of therapy may be less than a lifetime of paying for a BTKI. All right, what about patients with deletion 17p? So the more aggressive type, the type with the poorest prognosis. The recommendations are very similar to patients without deletion 17p. The recommendations are not as strong because there aren't as many studies to show the data in this subtype of patients. So you can see here we could use acalabrutinib with or without obinutuzumab, venetoclax and obinutuzumab, or zanubrutinib alone. But what we know we cannot use in patients with deletion 17p is chemoimmunotherapy like BR or FCR. Recall the deletion 17p predicts resistance to chemoimmunotherapy. So in that specific instance, you would move to the small molecules we've been discussing. All right. So CLL is an indolent disease that is considered to be incurable. Again, I could fight maybe with our faculty member who does stem cell transplant as to whether CLL is truly curable with a transplant or not. But I'm going to stay on the side of this is not a curable malignancy. So in my world, all patients that live long enough will eventually relapse and require second therapy, given their performance status allows at that time. So now let's think about what to do in the second and third line settings. So now we have a 63-year-old male with CLL with deletion 11q, well-controlled AFib, and gastroesophageal reflux disease. He received treatment with FCR 3 years ago and achieved a complete response. And he's recently been diagnosed with relapse CLL. So which of the following regimens is most appropriate for the patient at this point in his course? Is it A, repeat FCR, B, zanubrutinib and obinutuzumab, C, venetoclax and rituximab, or D, bendamustine, rituximab, and idelalisib? All right, again, there's more than one option in the real world, okay? Of the options I have given you here, the most appropriate is venetoclax and rituximab. Okay? There was a time, if you're old school like me, my friends, there was a time where we would consider the length of his remission and could we repeat FCR and those kinds of things. That is not anything like what we do now. So that is certainly not something that we would recommend in this day and age. There's no data to combine obinutuzumab with zanubrutinib at this time. And this triplet regimen that I have listed for you here has been studied, but is not recommended due to a very high incidence of toxicities, which again, we'll discuss in the upcoming slides. All right, so again, as I said, CLL is considered to be incurable by all of us except those who are transplanters. Everyone will universally relapse given they survive long enough to do so. All right, what we do when the patient relapses depends on their age, their performance status, and again, their fitness for therapy, what they've received in the past, how well did they respond to their previous therapy, and if they've been off therapy, such as a patient who received a year of venetoclax and obinutuzumab, how long has it been since they received that? How long, the time from their last therapy? So these are the current guidelines. So again, we're doing second and third line therapy for patients without deletion 17p or TP53 mutation. First choices or preferred regimens are acalabrutinib and zanubrutinib as category 1 recommendations, as well as venetoclax and obinutuzumab. On the right-hand side, there's our old friend ibrutinib as a category 1, but again, other. You could also consider venetoclax and rituximab as a category 1 recommendation. Recall I said that regimen is losing favor in the frontline setting, but it is still highly recommended in the second line setting. In very unique circumstances, you may have a patient who received a year of venetoclax and obinutuzumab who has now relapsed. So you could consider retreatment with that same regimen. There is not a defined time period as to how long that remission needed to last. And we have a newcomer here, pirtobrutinib, our non-covalent Bruton's tyrosine kinase inhibitor. And that would be, again, if you have failed a covalent one in the frontline setting. So let's take a look at this study, or these studies that showed us how we choose therapy in the second and subsequent lines of therapy. So first we have the ASCEND study, which was 310 patients now with relapsed or refractory disease who were randomized to acalabrutinib or the investigator's choice of therapy. And again, this study is a little older, so at that time, the second choice of therapy was either bendamustine and rituximab or idelalisib and rituximab. So a little more of a historical control arm here. The primary endpoint was progression-free survival by an independent review committee. And kind of no surprise here, acalabrutinib significantly prolonged progression-free survival compared to either of the two other arms. The progression-free survival benefit was very clear across all of the subgroups. Again, there was no difference in overall survival, which we don't typically see or expect in a study of an indolent disease. But what's worth noting here is the large number of patients that crossed over from the chemoimmunotherapy arms into the acalabrutinib arm, hinting here at tolerability as well. In the second-line setting, we studied venetoclax in what's called the Murano study. So this was venetoclax and rituximab versus this historical standard of bendamustine and rituximab in patients with relapsed or refractory disease. You can see here that, again, no surprise, venetoclax and rituximab had highly statistically significant advantage in progression-free survival at 48 months. Likewise, we saw some hints of better activity for patients with deletion 17p. Median progression-free survival also favored venetoclax and rituximab, as well as overall survival, again, which we don't typically see in chronic leukemia study. And again, this study measured undetectable minimal residual disease. That is not what we use to guide treatment decisions, but it favored the venetoclax and rituximab arm. It's also worth noting that venetoclax and rituximab is 2 years of therapy, not 1, but 2, still fixed duration or time dependent. Now we're going to look at a study where 2 BTKIs were compared to each other head to head in the relapsed and refractory setting. And this study is called Alpine. So this was a phase 3 trial of zanubrutinib versus ibrutinib in relapsed and refractory CLL. And it's worth noting here that no patient had received a prior BTKI. So this was not a study done in patients that had a mutation or refractory disease to a BTKI. They had received some other therapy, but not another BTKI. The overall response rate favored the zanubrutinib arm, and it was superior to ibrutinib with respect to progression-free survival. So again, it's kind of watching the sunset on ibrutinib here in the second and third line settings. All right, our newcomer on the block is pirtobrutinib. There is some information in your handout about this, but the large majority of the information regarding mechanism and what have you lives in the lymphoma handout because it was first approved for mantle cell lymphoma. So for a deep dive into this particular drug, I'm referring you to the lymphomas handout. Pirtobrutinib is a non-covalent BTKI, so abbreviated NC-BTKI, as opposed to ibrutinib, zanubrutinib, and acalabrutinib, which are all considered to be covalent BTKIs. So the difference here is that pirtobrutinib has reversible binding with a longer half-life compared to the covalent types. So there might be some advantages in terms of resistance as well as tolerability. Pirtobrutinib has been studied in a phase 1 and 2 study called Bruin. Bruin studies multiple different B-cell malignancies, so including mantle cell, CLL, and others. So the information on this slide has been teased out of the Bruin study regarding patients with CLL. So this was 317 patients, about 250 of whom had received a prior covalent BTKI. So in this study, patients were allowed to have received ibrutinib, zanubrutinib, or acalabrutinib first, as opposed to some of the other studies in the second-line setting. The overall response rate in this subgroup was quite impressive, almost 75%. And again, these patients were heavily pre-treated. Our median progression-free survival was 19.6 months, and median overall survival could not be estimated. So again, this is a phase 1-2 study, but certainly giving us some hints that this is a viable option, even in patients who have previously received a covalent BTKI. All right, now our second line setting and subsequent therapy for patients with deletion 17p. Once again, traditional chemoimmunotherapy is going to be off the table for a patient with deletion 17p. The preferred regimens in this setting are exactly the same as those in patients without deletion 17p. So acalabrutinib and zanubrutinib is a category 1 recommendation, as well as venetoclax plus or minus, and I apologize for the typo there, but plus or minus obinutuzumab in this setting. Other recommended regimens, ibrutinib as category 1, but again now other, and venetoclax plus rituximab, again in the second line setting. You could also consider retreatment with venetoclax and rituximab if the patient had achieved a remission, and pirtobrutinib if the patient had received a prior covalent BTKI. All right, getting harder now. What if our patient has now received both a BTKI and a venetoclax-based regimen? So these patients are called double relapsed or double refractory, depending on their what happened in the first and second line settings. In this setting, if the patient had not yet received pirtobrutinib, this would be a lovely time to try that. Likewise, we are starting to see the beginnings of CAR T therapy in CLL. So the approved drug in this space is called lisocabtagene maraleucel, but I will leave the CAR T discussion to our other speakers. This is also where we see some older drugs, such as our PI3K inhibitors, such as duvelisib or idelalisib. At one time, these drugs were quite popular, but we are also seeing the sunset on this class of drugs given their toxicities. Finally, in this setting of relapse after BTKI and venetoclax-based regimens, the guidelines say you could consider chemoimmunotherapy or immunotherapy. I have to say, in clinical practice, very few of my patients can tolerate FCR in the third line setting. My patients don't typically get healthier as their disease progresses. So again, I suppose that's an option, but in clinical practice, I don't believe that this is used very often. All right, so I've shown you a lot of data, but now I'd like to have you think about adverse effects, because again, we are thinking very carefully about our patients, their comorbid conditions, and the toxicities of these drugs. So I have several questions for you here. Our patient will be receiving venetoclax and rituximab for relapsed CLL. Which of the following statements about venetoclax is correct? A, pancreatitis is common. B, tumor lysis syndrome prophylaxis is required. C, lower extremity edema often occurs. Or D, visual changes are frequent. All right, the correct answer here is B. And if you're not familiar with venetoclax, you're probably saying to yourself, what? How can we consider tumor lysis syndrome in a chronic leukemia, in an indolent or smoldering disease? That is one of the big surprises of venetoclax, my friends. We did not expect that when we first studied the drug. So we do need to consider tumor lysis syndrome prophylaxis for patients that receive this agent. Some of these other ones I made up. So again, we're focusing here on the TLS risk. All right, second question about adverse effects. We have a 71-year-old female with newly diagnosed CLL who will be initiating therapy with acalabrutinib. Which of the following adverse effects are frequently seen with this agent? Is it A, hypotension, B, tumor lysis syndrome, C, headache, or D, periorbital edema? Okay, not tumor lysis syndrome this time. That's kind of the standout side effect of acalabrutinib is headache. We do see alterations in blood pressure with the BTKIs, but it's typically hypertension, not hypotension. And periorbital edema we see with some of the drugs for CML, but not CLL. All right, so now I'd like to spend a little bit of time differentiating between the toxicities of the agents we've been reviewing. So again, our old friend ibrutinib, we are seeing the sunset on this agent mostly for toxicity reasons. The major toxicity of this agent is cardiac in nature, probably because of its off-target effects. Because although it binds to Bruton's tyrosine kinase, it has activity against other enzymes as well, so that may be what contributes to these cardiac effects that we see. So we can see atrial fibrillation, both a recurrence in patients that have had it before, but also new onset AFib in about 10% of patients. Yeah, you could argue with me that's the nature of elderly people, but we definitely link it to the initiation of ibrutinib in many cases. Likewise, we see a pretty significant incidence of hypertension, both quickly and impressively. So some patients need multiple antihypertensive agents to manage this. Because of these risks, we recommend a baseline assessment of cardiac function prior to the initiation of any of the covalent BTKIs, but specifically ibrutinib, if that were to be used. What if you're like, but my patient has been on ibrutinib for 3 years, should I change them? Well, no, if they have been tolerating it well, we can continue ibrutinib until disease progression or toxicity occurs. But again, for a patient who is initiating therapy, you would think very carefully about their cardiac status. Other events that we see with ibrutinib, we see a not insignificant risk of bleeding. And again, this is likely due to ibrutinib's interaction with von Willebrand's factor and others. So patients are more likely to bleed on ibrutinib than not. Because of this, we recommend that therapy is held for anywhere between 3 and 7 days prior to a planned procedure. And again, how long you hold depends on the severity or the expected severity of that procedure. You would also need to be very cautious in a patient on anticoagulation. So much so that clinical trials excluded patients on concurrent warfarin. All right, fortunately, that's not a popular drug anymore, which is great. But for a patient that, say, for example, goes into AFib and needs anticoagulation, you would strongly consider a non-warfarin anticoagulant, such as a DOAC or enoxaparin. Likewise, it's not on the slide, but we should be asking our patients about any supplements that can affect bleeding risk, like vitamin E. We also see a pretty significant incidence of generalized muscle aches or joint aches, as well as transient diarrhea. And ibrutinib has CYP3A4 drug interactions, which may be problematic when a patient needs to initiate therapy for AFib, such as some of our amiodarones and other drugs for cardiac management. All right, our second generation's BTKIs, acalabrutinib and zanubrutinib, tend to be cleaner, right? Not zero incidence of cardiac events, but certainly less. So again, as I mentioned, kind of the standout adverse effect for acalabrutinib is headache. We see this very early on, and it typically resolves on its own. However, for a patient that is very uncomfortable, we recommend over-the-counter analgesics and actually caffeine. A good trip to Starbucks or a Diet Coke can actually go a long way here. We see a lower incidence of bleeding, hypertension, and AFib with acalabrutinib than ibrutinib. All right, and that is not just my impression, my friends. We actually have confirmed this in a very large trial. So this is called Elevate-RR, so Elevate Relapsed Refractory, where we did a head-to-head comparison of ibrutinib and acalabrutinib in the second-line setting. All right, so in terms of efficacy, there was no major difference. Okay, but the key secondary endpoints included adverse effects, including any grade of AFib or flutter and infections. And again, there was a clear difference here in that acalabrutinib had statistically significantly less AFib than ibrutinib. And also the incidence of AFib in patients who had never had it before was less in the acalabrutinib arm. There was no difference in the incidence of infections, but there were less other adverse effects, including bleeding, treatment discontinuations. Everything tended to be lower in the acalabrutinib arm. All right, so statistically significantly less AFib and a smaller incidence of other adverse effects. This study was conducted in the second-line setting, but I'm very comfortable extrapolating it to the first-line setting. So again, kind of waving goodbye to ibrutinib given its tolerability issues. In terms of adverse reactions for zanubrutinib, the most common ADRs we see here involve the blood. So myelosuppression is probably the highest of the BTKIs. We see some other pulmonary things like pneumonia and upper respiratory infection. There is a low incidence of hypertension and AFib compared to ibrutinib, but also a little caveat that zanubrutinib is the newest of the covalent BTKIs, so some of these numbers may be to a shorter follow-up time. So this is a slide, again, that I have prepared, summarizing the major toxicities of the BTKIs and comparing them to each other. So kind of for your studying purposes, again, acalabrutinib, famous for headaches, zanubrutinib, more likely to cause myelosuppression, ibrutinib, all sorts of cardiac things, hypertension and AFib, as well as bleeding. And notice on the far right, there's our new kid, pirtobrutinib, the non-covalent BTKI, which has none of the adverse effects in red. So hopefully that's because it's better tolerated. Again, this is a very new drug for us, so it may be just a short follow-up to this point, but we are seeing some hints that pirtobrutinib may be better tolerated than any of the other BTKIs. So here's hoping. All right, now thinking about adverse reactions of venetoclax. One of the patient questions involved prevention of tumor lysis syndrome, which again, we do not typically observe in a chronic leukemia or a chronic cancer. So venetoclax is so potent at causing apoptosis, at causing cell death, that in the phase 1 studies of this agent, there were actually deaths related to tumor lysis syndrome because we didn't know to look for that. It was a very unexpected finding. So we're much better at identifying that now. So this agent has what's called a ramp up dosage schedule. And that's not my slang term. That is actually what's used in the prescribing information. So you can see here our target dose is 400 milligrams a day. And we would start the patient at a very low dose and eventually or gradually work our way up to 400 milligrams per day. The manufacturer provides the drug in a very convenient dose pack for the patients to follow along. But again, the patients have to understand that they need to take those pills in a certain order. Likewise, venetoclax is involved with CYP3A4, so we need to occasionally account for drug interactions. I also have in your handout some other information about prophylaxis for tumor lysis syndrome in a patient that we feel is at high risk, and that is also covered in the acute leukemias module as well. All right, what about our PI3K inhibitors? I also mentioned that these agents were once quite popular, but now are very, very last line agents. And that is because, again, of their adverse reactions. So I'm a former transplant pharmacist, you guys. I am in my 15th year of recovery, I believe. But the toxicities of these drugs, idelalisib and duvelisib, look very much like graft versus host disease. But in this case, it would be auto GVH. So this is like an old friend of mine, but in a toxicity way. We see hepatotoxicity as well as GI side effects that in some cases are life-threatening. The diarrhea that occurs can be early, but then a serious colitis occurs somewhere between 6 and 12 months in a very significant amount of patients that oftentimes requires treatment with steroids and other agents. So again, these drugs are not benign in terms of autoimmune effects. We can also see a higher incidence of CMV as well as other infections like PJP. So again, certainly not a preferred class of drugs given how toxic they appear to be. All right, on the previous slides on adverse effects, you may have seen transient lymphocytosis. So I wanted to explain what that is as a single slide here. So lymphocytosis is where the B cells that have been resting in the lymph nodes shift out into the circulating blood, where they are eventually destroyed by whatever therapy we have chosen. So we initiate a patient, say, on acalabrutinib, and their B cells shift out of their lymph nodes into their peripheral blood, where they are eventually destroyed. That's exactly what we want. But if you were a patient who was following your labs, what might you notice? That you started this new drug and your lymphocyte count went up, right? Again, for a patient, that's probably a cause for alarm. You took this drug and your numbers got worse. So this is a huge counseling point for patients, okay? We expect or we hope to see an increase in your lymphocyte count in the upcoming weeks. This is not disease progression. This can usually resolve itself by about month 3 or 4. And it can occur with any kinase inhibitor for CLL. So the BTKIs, idelalisib and duvelisib, or venetoclax. All right, we notice that when we give those agents in combination with other drugs, this response appears to be somewhat less, but a huge counseling point for patients. And also, this is not an indication to change therapy. You just have to wait it out. All right, these next couple slides are just summary slides for all of the information I have given you. So what do we do for a patient without deletion 17p? In the first line setting, we would consider acalabrutinib plus or minus obinutuzumab, zanubrutinib, or venetoclax and obinutuzumab, with ibrutinib down there as an other. In certain circumstances, you could consider traditional chemotherapy, such as FCR, but that would be for a very specific young and healthy patient. In the second line and third line setting, you would consider what the patient has already received. You could consider a different or new BTKI, or initiate venetoclax and obinutuzumab. You could also consider venetoclax and rituximab in the second line setting. And depending on if they had received venetoclax and obinutuzumab in the frontline setting, you could consider retreating, or you could go to our non-covalent BTKI, pirtobrutinib, if the patient had already received a covalent BTKI. For patients with deletion 17p, again, very similar to without deletion 17p, the only major difference being there is no role for chemoimmunotherapy in this setting, and the recommendations are not as strong in terms of category rankings, again, just given the rarity of this subtype. For all patients, regardless of deletion 17p status, in the patients who are pre-treated with both a BTKI and a venetoclax-based regimen, these would be called double refractory or double relapsed. If you hadn't yet attempted pirtobrutinib, now might be the right time. Or in rare cases, if the patient was young and healthy and interested, we could consider CAR-T with lysocabtagene. We could also consider the PI3K inhibitors, but noting their autoimmune toxicity, you would have to be very careful about patient selection. And in very rare cases, you consider chemoimmunotherapy. Okay, wow, that's a lot of information, but I wanted to finish this section with some information about supportive care of patients with CLL. So we have a 63-year-old male who's been taking zanubrutinib for the past 18 months. And over the past 2 weeks, he's noted rapidly enlarging cervical, axillary, and inguinal lymphadenopathy. He also reports new fevers, splenomegaly, and unintentional weight loss. So which of the following is the most likely cause of this patient's new complaints? Is it A, Richter's transformation, B, zanubrutinib delayed hypersensitivity reaction, C, redistribution lymphocytosis, or D, tuberculosis infection? All right, so this patient has most likely developed what's called Richter's transformation. These other ones, redistribution lymphocytosis happens very early. There is no zanubrutinib delayed hypersensitivity reaction that I know of, and there's no association of these agents with tuberculosis. So Richter's transformation is a very unfortunate phenomenon. This is when an indolent CLL transforms into an aggressive lymphoma. Most of the time, this is diffuse large B-cell lymphoma, but very rarely it can transform into a Hodgkin's, into a classical Hodgkin's disease. This happens anywhere between 2 and 10% of patients. And there's a hint that this is happening earlier than we historically saw it. So maybe the newer agents are changing the course of the disease in some way. But what we do know is that these patients have a rapid disease progression. You have to move quickly, and their clinical outcome is very poor because typically when this transformation occurs, we see additional cytogenetic abnormalities, we see a lot more drug resistance. So whatever you're going to do, you would aim your treatment at that type of transformation, so at diffuse large B-cell lymphoma treatment or at Hodgkin's lymphoma treatment. But again, you got to move quickly and the outcomes are not good. All right, more supportive care. We have a 71-year-old female with newly diagnosed CLL. She has no drug allergies and will be initiating therapy with acalabrutinib. Which of the following supportive care interventions are appropriate to prevent complications from her underlying disease or treatment? Is it A, the zoster vaccine recombinant, B, dapsone, C, valganciclovir, or D, IVIG? All right, so the most appropriate answer here is the zoster vaccine recombinant. Shout out to you guys who chose IVIG. You may be a little older school like me. We did that at one point, but not anymore. All right, so let me show you these. We see a lot of issues with infections in the CLL population, and that is from both the disease itself, the effect on the CLL cells, but also immunosuppressive properties of treatment. So both the disease and the treatment cause long-term issues with opportunistic infections. Historically, we correlated this with a reduction in immunoglobulin levels. And so because of that, we consider or recommend anti-infective prophylaxis for any patients that receive kind of the heavy hitter drugs, purine analogs, bendamustine, PI3K inhibitors, and the anti-CD52 monoclonal antibody alemtuzumab, an old friend in CLL as well. A lot more information about this in the handout as well as in the cancer-related infections module. If you said IVIG, as I mentioned, this was a historical treatment of CLL because patients had low IgG levels, low immunoglobulin levels. What we found is that IVIG decreases the incidence of infections, but does not change the patient's overall course. So this is not the standard of care in all patients in this day and age. We could consider adding IVIG when the patient's serum IgG level is less than 500 and the patient has been readmitted for recurrent sinopulmonary infections such as that require antibiotics or hospitalization. So again, you need to show a low IgG level as well as recurrent infections to qualify for IVIG, which was clearly not our example patient. For patients who are receiving, again, the heavy hitters such as purine analogs or PI3K inhibitors, we should consider PJP prophylaxis with sulfamethoxazole and trimethoprim or its equivalent. And any patient with CLL who is receiving treatment should receive testing for hepatitis B. Again, there's a lot more information about this in the cancer-related ID section of our modules. We should also consider vaccinations in patients with CLL. All patients should receive the annual influenza vaccine as well as the COVID vaccine, the pneumococcal vaccine if they're due for it, as well as the recombinant zoster vaccine. Side note here that all live vaccines should be avoided, again, because given the patient's immunosuppressed nature. The zoster vaccine recombinant is not live, so that is a shift from the older product. But again, patients should be cautioned that they need certain vaccines, but no live ones. Okay, so that concludes our section on CLL, and we're going to finish up with a discussion about the other side of the stem cell cascade, CML, or chronic myeloid leukemia. And this is my all-time favorite cancer, everybody, so I am so happy that I get the chance to speak about it to you today. So CLL is a myeloproliferative disorder of the primitive hematopoietic stem cells. The hallmark translocation in chromosomes in CML is between chromosomes 9 and 22. So the chromosomes actually break arms and switch. And that fusion protein results in an oncogene called BCR-ABL. That chromosomal translocation is called the Philadelphia chromosome, which was the first genetic mutation that we were ever able to link to a cancer. And it was also the first cancer that we ever rationally designed a drug against. So CML is like a nerd's dream here, including mine, talking about the genesis of the disease, but then just developing a drug against that genesis. Historically, we considered 3 phases of CML, chronic phase, an accelerated phase, and then a blast phase. Some of the newer literature has only 2 phases, chronic phase and then advanced phase. So this is a chronic disease. So our primary goal is to keep you in that lowest phase, in the chronic phase, where there is only one genetic mutation and we don't want to see any progression to others. Because this could potentially be lifelong therapy of a chronic disease, I want to minimize the toxicities of whatever treatment we choose. But I have here as a 4th potential goal, treatment-free remission. Can we ever stop these drugs? And the answer is maybe, right? I will show you some data for that. For the rare patient who shows up in a more advanced phase, either progresses into one or presents in an advanced phase, my entire goal is to get them back into chronic phase, is to minimize their disease burden, minimize those chromosomal abnormalities, back down into chronic phase. All right, so in CML, there are 3 types of responses. I will very briefly go over them, but again, there's more detail in your handout. So the first is called a hematologic response, and this would be a normalization of blood counts. Okay, this is only a laboratory parameter, but it's the most basic of all types of responses. Then we move into what's called a cytogenetic response, and this would be how many cells or how many chromosomes have that Philadelphia chromosome, have that mutation. A complete cytogenetic response would be 0% of those cells, and that's the gold standard right now, is the achievement of a complete cytogenetic response. Kind of the holy grail of responses is called a molecular response. So this would be the disappearance of the BCR-ABL1 gene. Okay, not the chromosome, but the gene itself. So this is based on a log rank scale. And again, big long definition there. But kind of an up-and-coming goal or a new endpoint is called MMR, so major molecular response, a more than 3 log reduction in the actual genes. All right, so we have a 65-year-old female with a history of psoriasis, IBD with diarrhea, and seasonal allergies. She's presented for a physical as required by her new insurance plan. And her blood work revealed a white blood cell count of 94,000 with normal hemoglobin and platelets. She underwent a bone marrow biopsy, which was markedly hypercellular, and her cytogenetic analysis was positive for translocation 922, the Philadelphia chromosome, confirming chronic phase CML. Her UDOS long-term survival score reveals that she has intermediate risk disease. So given this information, which of the following is the most appropriate therapy for this patient in the frontline setting? Is it A, imatinib, B, dasatinib, C, ponatinib, or D, bosutinib? All right. So of the choices that I gave you, the most appropriate is dasatinib. Okay, why is that? Well, she has intermediate risk according to her UTOS score, which we will discuss in the upcoming slides, which makes her a good candidate for both dasatinib and bosutinib. But this patient had a GI problem or a GI comorbid condition, and that led me towards dasatinib and not bosutinib, given the tolerability of those agents, which we will also discuss. All right, so the preferred drugs in this setting are called BCR-ABL tyrosine kinase inhibitors. So again, inhibiting the enzyme that is produced by that fusion protein. There are 6 drugs in this class, with imatinib being the prototype and the newest one called asciminib. Everything is compared to imatinib in terms of potency. And you can also see here that although these agents are specific for BCR-ABL, they also have other targets, which accounts for their use in other diseases. So again, the use of imatinib for GI stromal tumor is due to its off-target toxicity in c-KIT, but that also may explain some of the toxicities that we'll see. All right, asciminib is our newest agent. It is slightly different than the other drugs in this class. It targets the ABL1 myristoyl pocket. So because of that, it's called a STAMP inhibitor, specifically targeting the ABL1 myristoyl pocket. And this locks that BCR-ABL region into an inactive conformation. So slightly different effect on BCR-ABL and tyrosine kinase than the other drugs in this class. It was originally approved for in the second and third line setting, but now has been moved up to first line treatment as of October 2024. All right, so I am going to very briefly summarize the studies of these agents because they're somewhat historical at this point. All right. Imatinib, this study was published in 2000 called the IRIS trial, and this was the groundbreaking trial of drugs in this class. This was imatinib versus the standard of care at that time, interferon and cytarabine. So, and the cytarabine was subcutaneous. So you can imagine that that was not the popular arm to be randomized to. Hands down, imatinib was better. It rocked the world of CML. We saw complete cytogenetic response in 18 months in more than 3/4 of patients. And they maintained that for 5 years in some cases. Likewise, we saw freedom from progression in a statistically significant number of imatinib patients versus the standard of care. When we get out into 5 and 10-year data, you can see there's not a lot of data reported, and that's because nearly everyone who received interferon and cytarabine crossed over into the imatinib arm. So again, without question, imatinib changed the way we treat CML. But there was a little surprise with this data, and I like to refer to this as ghost in the machine. So if you have heard me give this lecture before, you may know that I have a major crush on the musician Sting, and I'm actually blushing right now. But Sting and his group, The Police, had an album called Ghost in the Machine, and that is what we observed with imatinib. It was like a machine. It was cranking out these amazing responses. But at year 2 or 3, some patients started to lose that response. Okay, why might that be? 2 reasons. 1, adherence, and 2, the development of resistant mutation. Okay, so that spurred us to develop other agents in this class that may not be as susceptible to mutations. Again, I'm also hinting at adherence is going to be a big deal for these patients. All right, our second generation BCR-ABL TKIs include dasatinib, which was compared to imatinib in a trial called Decision. A lot of data on this slide, but what you should take is that patients achieved a complete cytogenetic response with dasatinib more often and faster than patients who received imatinib. So the response we were interested in at that time occurred sooner and in more patients when dasatinib was used. We saw similar findings to another second-generation drug called nilotinib. Two different dosages were compared to imatinib in this setting, and once again, complete cytogenetic response, which was the gold standard of response at that time, occurred faster and in more patients that received nilotinib compared to imatinib. Okay, but another big point here for both dasatinib and nilotinib, no difference in overall survival. So we get you where you need to go faster, but we don't see any difference in the long term. And broken record here, bosutinib was studied against imatinib in the frontline setting in a trial called B4. And again, a greater number of patients achieved a complete cytogenetic response at 12 months. So they got there faster and more of them. However, overall survival was not different between the two agents. Very recently, a trial of asciminib in the frontline setting was published. This is called ASC4 FIRST. So an interesting study design. They took patients with newly diagnosed chronic phase CML and randomized them to either asciminib or an investigator-selected TKI. So the physician could choose which agent if asciminib was not assigned. There were two primary endpoints, but notice this time we're studying major molecular response, or MMR, not complete cytogenetic response. All right, so stepping it up here. The comparisons were between asciminib and any TKI, or asciminib and the patients that were selected by their physician to receive imatinib. All right, this is a complicated slide. So asciminib versus any TKI, major molecular response at 48 weeks was highly in favor of asciminib. And we had that same finding when asciminib was compared to the patients who received imatinib. However, we did not see a difference when patients who received a second-generation TKI were compared to patients who received asciminib. But notice at the bottom, that was not a primary endpoint, so we cannot make any conclusions from that. All of the agents were very well tolerated, but we did see a higher rate of discontinuation in the patients who received imatinib. So what we can take from this is that asciminib is probably better than imatinib. Asciminib may be better than the second-generation TKIs, but we can't say that for sure, and I certainly cannot tease out differences between the second-generation TKIs. So based on all of these findings, the current recommendation is for a patient who has low-risk disease. What does that mean? There are multiple scales to estimate a patient's risk, and it would be either low, intermediate, or high. Pharmacists typically don't calculate that risk score, so that information should be provided to you. For a patient who is low risk, any of the BCR-ABL TKIs are category 1 first-line choices. But for patients who are intermediate or high risk, any of the BTKIs are first-line treatment except imatinib. All right, it may be used, but it's not the category 1 first-line choice. All right, notice asciminib has also been recently given a category 1 recommendation in this setting. How do we choose between them? There are no direct comparisons between the second-generation agents, so choice would be dependent on things like the patient's risk, what are the toxicities, what is the cost, what are possible drug interactions, and what do the patient and physician prefer. You may be thinking, what about high-dose imatinib? I've heard of that. The answer here is no. Okay, that is not recommended as initial therapy, again, because the responses were not different at 12 months, and this was more toxic, so higher rates of dose interruption and reduction. All right, so let's talk about adverse effects. So how would you choose between them? I have created this table, and I have highlighted for you here in bold what the major toxicities are. All right, so notice for imatinib, annoying but manageable side effects. Dasatinib, pleural effusions, pleural effusions, pleural effusions. I cannot say that enough, but about a quarter of the patients will require thoracentesis for a pleural effusion. So you should not select dasatinib for a patient with pulmonary problems. Okay? Likewise, bosutinib has an incidence of diarrhea, so you should not select it for patients that have GI issues, like the patient in our case. Nilotinib is a little dirtier than the others. It has some cardiac issues like QTc interval prolongation, as well as a metabolic syndrome like insulin and cholesterol disorders. Ponatinib, we'll discuss on other slides. And asciminib, very new, but so far quite well tolerated. All right, so our patient started on dasatinib, 100 milligrams every day. And after 12 months of therapy, she has not achieved a complete cytogenetic response. We have spoken to her, and she has no drug interactions, and she's been adherent with her therapy. So which of the following is the most appropriate intervention for her at this point in her course? Is it increase to dasatinib twice daily, change to high-dose imatinib, order a BCR-ABL1 mutational analysis, or change to asciminib? Okay, because we have already ruled out drug interactions and non-adherence, what is most appropriate to do is look for a potential development of a mutation. We should order a mutational analysis and then tailor our subsequent therapy appropriately. So in the second line setting, if we need to change drugs because of disease progression, not because of intolerance, we should order that BCR-ABL kinase domain mutational testing. For a patient who was on imatinib, you would change to an alternative TKI, any of the others. But for a patient who started on a second or third generation, you would change to another second or third generation TKI, not imatinib. So you never go backwards. What about the third line therapy? And again, this is very rare, but these patients are now a candidate for ponatinib, as well as asciminib has an FDA approval in this setting. Historically, allogeneic stem cell transplantation was the treatment of choice for CML, but notice I haven't mentioned it yet. And that's because we only consider stem cell transplant in patients who have progressed to third line therapy or beyond. So certainly not standard of care anymore. And in the third line setting, just a note here, we have closed the door on omacitaxine. It was currently indicated in this setting, but is no longer being manufactured. So a well-warranted goodbye there. All right, just a moment about resistance. Primary resistance is very rare. Okay, what usually happens is the development of secondary resistance. So after the patient has been on a TKI and develops resistance, there are numerous potential resistance mutations. I have them all detailed, I hope, very nicely in your handout. But the one that we are most concerned about is T315I. This confers resistance to imatinib, dasatinib, nilotinib, and bosutinib. So your choices of therapy are very limited when we see that T315I mutation. We call that the gatekeeper mutation. And I do think that's a testable one because, again, it certainly dictates what therapy is possible for our patients. So we don't recommend resistance testing in the first line setting, but if we need to progress to the second line or subsequent, that would be very useful information. As I mentioned, the T315I mutation is the worst or most severe. We could use ponatinib or asciminib in this setting, and notice the dose of asciminib is going to be much higher than in the frontline setting for other or no mutations. And again, we could consider allogeneic stem cell transplant in this situation on the rare times that it does occur. All right, I mentioned that I wanted to discuss ponatinib toxicities separately, and that's because these are more severe and potentially life-threatening compared to the other adverse effects of drugs in this class. So ponatinib actually had a drug safety communication issued in 2013 because of life-threatening blood clots and narrowing of vessels in the extremities. It was eventually withdrawn from the market, but then reintroduced with a REMS program. The current recommendations are to start the dose at 45 milligrams a day, but then back off once the response has been achieved, once you see that complete cytogenetic response or major molecular response. So actually decreasing the dose over time to hopefully avoid some of these toxicities. How do we know if a patient has achieved a complete cytogenetic response or major molecular response? That is all done through some pretty highly sophisticated testing. We also need to consider, though, where is the patient within their clinical course? So is it the first 3 months, the 6 months, or 12 months? We can do so with bone marrow cytogenetics, but also with a PCR, a polymerase chain reaction. So I have a lot of information about this in your handout. Again, pharmacists don't typically order these tests. We would just be asked to comment on how we proceed given the results. And what you should take from this is if the response we expected does not occur, or the patient has a response and then loses it, we should consider a kinase domain mutation analysis to see if a mutation has occurred. All right, getting into some patient counseling points here. Which of the following counseling points should be included in your discussion with our patient about her treatment for CML? Is it A, food does not impact the effectiveness of TKIs? B, she can miss 1 dose of TKI per week without a difference in treatment outcome? C, TKIs should be taken once daily to maintain serum steady state concentration? Or D, TKIs may be discontinued if major molecular response is sustained for 2 years. Okay, so the answer here is D. The very important word in the statement here is may be discontinued. Not can be, but may be in very specific situations. And hopefully the upcoming slides, I will show you why the other answers were not correct. All right, I like to call this slide pharmacist stuff. All right, these are things that I think about and hopefully you will think about as well. Notice that most of the agents are taken once daily, but nilotinib is taken twice daily, and asciminib could be either once or twice daily. That would certainly factor into my choice of therapy for a patient who's going to take this therapy lifelong. Likewise, I need to counsel the patient about whether they take this oral drug with or without food. So again, you can see there's some advantages, to some there's no difference. Likewise, some must be taken on an empty stomach, which makes compliance harder. Metabolism is a big deal, lots of considerations about drug interactions, and again, so many possibilities that I can't fit them all on this table. Likewise, some of these agents I need to counsel about acid reducers like PPIs and H2A receptor antagonists, because we know nobody in this country takes those drugs, right? So all things I would consider when making a recommendation, but also when I'm counseling a patient. I wanted to have a little discussion about adherence to TKI therapy. So again, CML is considered now a true chronic disease. We are so good at treating it that the life expectancy of a patient with CML is exactly the same as a patient who does not, which is such an advance in therapy, but also leads us to concerns about financial toxicity and adherence because of other side effects. So this was actually studied in a trial called Adagio, and this was specific to imatinib, but I am very comfortable extrapolating it to the other agents. And what it showed us was that poor adherence was the #1 factor contributing to relapse. So not the development of mutations or drug-drug interactions or what have you, but adherence. All right, so clearly this is a big role for the pharmacist to play in terms of monitoring for adverse effects, educating the patients, intervening if financial concerns become important. So what a role for us right here, this slide. So can we ever stop the TKIs? And the answer is maybe in some patients, okay? Again, this is truly a chronic disease, so I'm thinking for the long term, as well as adverse effects, quality of life, and financial concerns, like I said. But for other patients, maybe fertility planning is an issue, or other things about general life that I might want to consider a treatment break, or hopefully stopping entirely. So there have been several studies that investigated TKI discontinuation, and we don't call this cure, okay? We call this TFR, treatment-free remission. So is it possible to achieve a TFR when we stop one of these BCR-ABL tyrosine kinase inhibitors? The studies that have been conducted have very strict eligibility criteria. All of the patients had to maintain a major molecular response for at least 2 years. So the holy grail of responses, and the minimum was 2 years, but some of the studies were even 3 or 4 years. All right, so very specific patient criteria. And what we saw was that about 40% of the patients who stopped their therapy achieved a treatment-free remission and were able to stay in it. Okay, so slightly less than half of the patients were actually able to stop therapy. Of the patients who lost their response, all right, whose CML recurred, almost all of them did so very quickly. Okay, so if your disease is going to come back, it happens usually within the first 6 months, and restarting your original drug was successful in almost everyone. Okay, so the benefit would be you can come off therapy, and if you relapse, we'll know it quickly, and you will hopefully be able to get right back into a remission by restarting your drug. The counter argument to this is that you need to follow labs very closely, sometimes more often than for a patient who's on therapy. So the trade-off is the patient actually has to have more frequent lab work. Likewise, we can observe what's called a treatment withdrawal syndrome, where patients complain of vague muscle aches and joint pain. I don't have a real good sense of the mechanism of that, but what I do know is that it's typically transient and can be managed with over-the-counter pain control medications. But for the very rare patient that cannot tolerate that withdrawal syndrome, restarting their original drug also eliminates those symptoms. Okay, so this is, again, maybe the beginnings of stopping therapy for CML, which, again, if you've been around a long time like me, like what a change this has been from the days of transplant to now stopping these oral drugs. All right, the guidelines would say you can consider stopping TKIs outside of a clinical trial only in patients who meet the criteria on this slide. So a stable molecular response for at least 2 years, access to frequent and reliable monitoring, because again, the implication is that relapse will happen quickly and you could get the patient right back into a remission by restarting their drug. But again, the patients have to consent to this process after a thorough discussion. Okay. In my practice, you guys, many of my patients are just like, no, like, why would I rock the boat? I'm good. But I also have other patients that are very interested in giving this a try. So it's definitely worth a conversation, and we have to make sure the patient understands the risks and benefits. All right, very briefly here at the end, what do we do about a patient who presents in an advanced phase or progresses into an advanced phase because of noncompliance or drug interactions or mutations? All right, my goal is to beat those patients' disease back down into the chronic phase. Just get them back into chronic phase. If they had been on imatinib, you could use higher doses of the TKIs, higher than what is indicated in the first line or chronic phase setting. If they had been on a second generation TKI, you would switch to a different second generation TKI. So again, you never go backwards to imatinib. We can consider ponatinib and asciminib in this setting. The doses are not clear. And again, I would start thinking about a transplant in these patients given their high-risk disease at this point. For the very rare patient in blast crisis, again, my goal is to get them back to chronic phase, but that is not often successful. You would assume that a CML converts into an AML, but that's actually not what happens. We can see conversion into an AML, but we can also see conversion into an ALL because this is a stem cell disease. So a conversion can occur on either line or either lineage. So you would aim your treatment at whatever type of acute leukemia that has developed. So I will leave that to Dr. Parasanati and his expertise. But for a patient that develops an AML, you would do AML-based therapy. For a patient that develops an ALL, you would do ALL-based therapy. You could also add a TKI while you initiate that traditional chemotherapy. But again, you need to initiate traditional acute leukemia therapy in these cases. If the patient achieves a second chronic phase, you need to take him to transplant right then. So during the initiation of leukemia therapy, we should be consulting for a stem cell transplant. Again, this is quite rare, but what I would expect is a trick question about a CML converted into an ALL or something along those lines. That is all that I have for you. I really appreciate everyone's attention. Again, I appreciate the opportunity. Thank you again to ASHP and ACCP. It's such a privilege to spend this time with you. Good luck to everyone, and hopefully I'll see you soon.